So before starting the session, I want to ask you a few questions regarding this. So can you tell me something about schizophrenia in general? What do you have about schizophrenia? Anyone? Anything related to schizophrenia? Splitting of mind, okay, or loss of touch with reality, okay. Delusions are very marked, okay, or positive and negative symptoms. So, what differentiate between the depression and schizophrenia? Both are psychiatric illnesses, but the differs. You know? How can you differentiate the terms neurosis and psychosis? One is neurosis and one is psychosis. In simple, you can say.
Neurosis we are the touch with reality.
Touch with reality. Okay. In psychosis, reality testing is not there. Okay. Or any other differentiating points between neurosis and psychosis? Insight. Insight will be present in case of neurosis and insight will be absent in case of psychosis. What do you mean by insight? Awareness of being ill. That is called insight. So, psychotic disorders are primarily characterized by psychotic symptoms, you know, like delusions and hallucinations. So, delusions and hallucinations will be prominent in case of psychosis. So, it is possible to see psychotic features in case of neurosis. Can delusions or hallucinations will be there in case of neurotic disorders? Anyone? Psychotic symptoms will be there in case of neurosis or not? Is it possible? How? Example? Okay. So depression can be associated with the psychotic symptoms like delusions and hallucinations. Even OCD, obsessive compulsive disorder, in severe cases can be associated with the complete lack of insight. Okay, so there can be some disorders, that is neurotic disorders, in which there will be lack of insight. Okay, it's not like that only psychotic disorders are having lack of insight. Neurotic disorders can also have this symptom of lack of insight. Okay, so in my presentation, I would like to give you a small introduction about schizophrenia under these headings. First, we'll discuss a case, followed by introduction and milestones of schizophrenia. Then, regarding its epidemiology and etiology, then diagnosis and clinical features of schizophrenia according to ICD-11 criteria, then course and prognosis, management, and finally homeopathic perspective of schizophrenia. So I would like to discuss a case which I treated during my MD time in Kottayam. It is the case of schizophrenia. It's a real case which I treated during my MD period. So regarding the identification data of the patient, it is the case of 47-year-old male, plumber by profession, and the information was given by his mother, and the reliability is reliable. We can rely the information. And what are the criteria for reliability of information given by patient or attendant? What are the criteria for reliability? There should be constancy, consistency, or coherency. There are 5 C's, 5 C's regarding reliability of information. The information should be constant, the information should be consistent, the information should be coherent. Coherent matlab understandable. The information should be based on the concern of the patient, how much the informant is related with the patient. Okay, these are the 5 C's of reliability. You have to take care of these features. And the patient presented with these complaints, irrelevant and continuous self-talk. Self-talking is one of the main clinical manifestations of schizophrenia. Self-talking and self-laughing, increased anger, suspiciousness towards his mother, fears that neighbor coming to kill him. Always says, "Don't kill me." And hearing a male voices of his neighbor, talking about wife and son that they are coming now, always calling police by saying, "Neighbor is talking through a computer and satellite. My words are sending via it to reach another person." These are the symptoms of real paranoid schizophrenia patients. And says, PM Modi will call him, then he will take bath. Only after the call he will go to take a bath. And he is running away from home, wandering tendency with the sleeplessness and poor appetite and thirst. The complaint started since 1 month. Coming to the history, the complaint started with sleeplessness. He used to sleep only for 2 to 3 hours, and then the parents consulted a psychiatrist and admitted to a private hospital for 9 days. The patient's mother couldn't afford the hospital expenses, then they took discharge against medical advices and used allopathic medication in the hospital for the next 9 days. After coming back home, he ran away from home, wandering tendencies started again. Managing him at home was difficult for their parents. Then they came to the OPD of our institution. And there is the history of a dispute with his wife, and he used to have constant quarrels at home, and they got divorced 6 years back. So there is a strong precipitating factor, divorce. Having one son, now staying with the wife. He tried to meet his son after the divorce, but the wife did not allow him. The patient is now staying with his mother. After the divorce, he gradually started with the murmuring, and the religiosity increased. And also simultaneously there was a dispute between the patient and his brother regarding a property 10 months back. Since then he developed a fear towards police. During the quarrel, patient became afraid, not able to withstand there, and left from the situation by keeping the mother all alone. So you can see two strong precipitating factors for this episode. One is divorce, and second one is dispute with his brother. These are the two strong precipitating factors for this schizophrenic episode. Okay? And there was no history of any neurosis in childhood. His pre-morbid personality was very reserved, introverted, fastidious, and religious. And the patient also had a problem with the hard stools and passes alternate days. And coming to the generals of the patient, he desired for tea, refreshing things, and aversion to milk, thermally hot patient, and nothing abnormal was detected on general physical examination. Coming to the MSc part, on general appearance and behavior, the patient was conscious, cooperative, interpersonal relationships was poor, eye-to-eye contact was also very poor. He feels sleepy during the interview, tired look often closes his eyes with the drooping of upper eyelids. The symptom can be a side effect of antipsychotic medication which he took. This tiredness and drooping of eyelids. Because antipsychotic medication can cause what? Sedation. Sedation can be caused by antipsychotic medications. And the psychomotor activity was decreased. Coming to speech, it was irrelevant. Volume was normal. tone and also reaction time was normal. Affect was inappropriate, congruent, average range, and labile. Mood was anxious, thought flow increased, and thought content is full of delusions. Different types of delusion like delusion of preference, delusion of persecution, delusion of grandiosity, and also bizarre delusion. I know you are all familiar with all these type of delusion. What do you mean by bizarre delusion? Which is completely impossible. It is completely impossible. In this case, what is the bizarre delusion? That is possible. That is somewhat possible. He can come and tell him. Satellite. There was a symptom. His thoughts were grasped by using a satellite. That is not possible. It can be taken as a bizarre delusion. Perceptual disorder, auditory hallucination was there. It was very prominent, and orientation was intact. But here, all the higher mental functions like attention and concentration, memory, judgment, abstract thinking, general information, and intelligence was adequate. And insight was grade 1. That means what? Complete denial of illness. Complete denial of illness. That is grade 1, which is most commonly seen in schizophrenia patient. Grade 1 insight. Okay. Okay, so this patient was treated by stramonium 200 followed by stramonium 1M, and the patient improved after taking stramonium 1M potency. Okay, so I want to tell you how a schizophrenia patient will present in an OPD. Okay, okay. Then coming to schizophrenia introduction. As you know, schizophrenia is a group of disorders. If you see DSM-5, you can see the term schizophrenia spectrum disorders. It is not schizophrenia. It is a spectrum disorders. Means it's a group of disorders, related disorders. Okay, having different etiologies, different clinical presentations, and different treatment response and causes of illness. And the signs and symptoms are variable. And the signs and symptoms of schizophrenia can be related to thought, behavior, emotion, thinking, and cognition. So it is a major illness. Schizophrenia is not like a minor illness. It's a very serious and major illness which can cause problems with both the patient as well as his bystanders. Okay. Then regarding the milestones of schizophrenia, how the terminology schizophrenia came. So first of all, a French psychiatrist Benedict Morel, उन्होंने एक term coin किया, that is called dementia precoce. Dementia precoce. What is the meaning of dementia precoce? It's nothing but dementia precox. Dementia precox. It is a French terminology for dementia precox. Dementia means what? It is the deterioration of cognitive function. And precox means early onset. Onset in the early adult or adolescent life. So the term dementia precoce was given by Benedict Morel. Following Benedict Morel, one of the famous figure in schizophrenia is Emil Kraepelin. Emil Kraepelin, he translated the term dementia precoce into dementia precox. English translation, dementia precox. The meaning was same. Dementia means gradual deterioration of mental functioning, and the onset is in the early life. Dementia precox. And he also coined another term called MDP, means manic depressive psychosis. Manic depressive psychosis. But these two illnesses differ, both the dementia precox and manic depressive psychosis. How? Dementia precox is having a continuous course of illness, but the manic depressive psychosis is having an episodic course of illness. That's the main difference between dementia precox and manic depressive psychosis. Okay, based on the course, dementia precox, that is schizophrenia, is having long-lasting course, continuous course, whereas MDP is having a episodic course. And he also coined another term called paranoia. What do you mean by paranoia? Paranoia मतलब suspiciousness. Paranoia मतलब suspiciousness. But he used the term paranoia to describe persistent persecutory delusions. To describe persistent persecutory delusions. So these are the three contributions of Emil Kraepelin. One is dementia precox, then manic depressive psychosis, and paranoia. Then came very important figure in schizophrenia, Eugene Bleuler, who coined the term schizophrenia. Schizophrenia term was coined by Eugene Bleuler, and he divided the symptoms of schizophrenia into two types. One is called primary symptoms, fundamental symptoms, and secondary symptoms or accessory symptoms. Okay, and what are the fundamental symptoms of schizophrenia? The abbreviation is 4A's. You can remember the letter 4A, which is one is looseness. मतलब loosening of association. What is loosening of association? Loosening of association क्या है? Separating from reality. ठीक है और कुछ? How will you assess this loosening of association? Through speech. So there will be lack of connection, lack of logical connection between the thoughts. That is called loosening of association. Second one is affective disturbances. Affective disturbances in the form of inappropriate affect, or we can say blended affect, which is very common in schizophrenia. Blended, flat affect. Okay. And third one is ambivalence. क्या होता है ambivalence? So ambivalence will be, there will be conflicting ideas, conflicting ideas or conflicting images at the same time in an individual. That is called ambivalence. मतलब same time the patient is having love and hate towards one object or one person. That is called ambivalence. And also autism. Autism मतलब withdrawing to the self. Withdrawing to the self. These are the fundamental symptoms of schizophrenia. Baki all the symptoms are regarded as accessory symptoms of schizophrenia. Okay. The next contribution given by Ernest Kretschmer. Ernest Kretschmer. What is the contribution of Ernest Kretschmer in schizophrenia? Based on the personality types. So he told one observation. मतलब schizophrenia is most common in persons who are very lean, thin. Schizophrenia is very common in persons whose body type is very slim, lean, or we can say asthenic type of personality. Whereas depression is very common in picnic type of body, मतलब very fat, chubby body. That was the contribution of Ernest Kretschmer based on the physical appearance, body types of persons. We can say whether he is prone to develop schizophrenia, depression. Okay. Then this is very important. First rank symptoms of Kurt Schneider. So Kurt Schneider developed 11 symptoms which are diagnostic of schizophrenia. They are called Schneiderian first rank symptoms of schizophrenia. So 11 symptoms, I think you are familiar with all these symptoms. There is no need of any explanation, I think. Okay, audible thoughts means audible thoughts. It is the type of auditory hallucination in which the patient can hear his own thoughts. That is audible thoughts. It's a kind of first person auditory hallucination. Then voices heard arguing means, so that is called third person auditory hallucination, 3PH, third person auditory hallucination. Then voices commenting one's action, running commentary auditory hallucination. Okay, then thought insertion, you know. What is thought insertion? The patient is feeling, somebody is putting thoughts into his mind. Thought insertion. Thought withdrawal matlab, somebody is taking the thoughts away from me. Some external agency is taking the thoughts from me. Thought broadcasting matlab, my thoughts is diffusing in the surrounding. Whatever I am thinking, other persons can also came to know what I am thinking. That is thought broadcasting or thought diffusion. Then made feelings or made affect means some external agency is doing. This not my effect. This not my emotion. Some external agency is imposing this effect on me. That is made affect or made feelings. Made impulses, same. These impulses or these actions are not mine. Some external agency is putting or controlling me. Okay. Then made volitions or actors, same meaning. Then somatic passivity matlab sensations, bodily sensations in the form of tactile hallucinations. Okay? Then delusional perception means normal perception, but the patient is having a separate meaning. That is called a delusional perception. Okay? These are called Schneiderian first rank symptoms of schizophrenia, which is very important in psychiatry. Then coming to epidemiology of schizophrenia, what are the main factors which contribute to the development of schizophrenia? One factor is gender and age. What is the relationship between gender, age and schizophrenia? Is there any relation? Is there any predominance sex-wise? According to ICD-11, males are a little bit more affected than females. Okay, what about the age group? Average age group बताओ. 17. Okay, so schizophrenia in male, it is a little bit earlier onset compared to females. So the average age of schizophrenia is 25 years. 25 years is the average age group of schizophrenia. But in males, it is having an earlier onset like 15 to 25 years. In males, in females, it is 25 to 35 years of age group. Okay. Generally, we can say schizophrenia is the disorder affecting 15 to 55 years of age group. 15 to 55 years of age group. Before 10 and after 60, it is very rare. It can be there, but it is very rare. Before the age of 10 years and after the age of 60 years, schizophrenia is very rare. Okay. Then what about the prognosis based on the gender? The prognosis is generally poor in case of males. Why? Because males are affected more with the negative symptoms of schizophrenia. So negative symptoms as compared to positive symptoms are having poor prognosis. In females, there are more positive symptoms such as delusions, hallucinations and all, which is more easy to treat compared to negative symptoms. Okay. Then infection and birth season and schizophrenia का relation क्या है? Any specific infection can cause schizophrenia outbreak? So infection during pregnancy, especially influenza virus infection. Influenza virus infection during pregnancy, especially during second trimester, can cause or can predispose the development of schizophrenia in the child. Okay, influenza epidemics can cause schizophrenia later in life. Okay, and what about the substance abuse and the schizophrenia? It's very important. Substance abuse is a very common comorbidity of schizophrenia. You can see about 90% of individuals affected with the schizophrenia use a substance. Okay, and the main substances are nicotine. Nicotine is, we can say 90% of the individuals who are suffering from schizophrenia smoke. Why? Is there any relation with the smoking and schizophrenia? Anxiety will reduce. Okay, so actually, schizophrenia patients take nicotine as smoking as a form of self-medication. Self-medication. Why? Because nicotine can cause disturbances in the dopamine levels. Okay, which is the main culprit in schizophrenia. So, after smoking, they feel like that they are improving their cognitive health. Okay, cognitive symptoms will be reduced after smoking, and there is a tendency to decrease the hallucinations and delusions after smoking. So, as a form of self-medication, patients used to smoke a lot. Okay. Okay. Then coming to the etiology of schizophrenia. So schizophrenia, we can't say only one etiology. Due to this, schizophrenia is happening. Schizophrenia is a multi-etiological disorder. Okay, मतलब comprising both genetic factors as well as environmental factors. So coming to the genetic factors, we can see lots and lots of genes which are implicated in the etiology of schizophrenia, and the main locus in which these genes are located are 1q, 5q, 6q, etc. These are the main locus of these genes are located, and the main genes implicated are alpha nicotinic receptor DISC1 means disrupted in schizophrenia 1 gene, then GRM3, COMT, then neuroregulin 1, RGS4, then D amino acid oxidase, proline dehydrogenase, dysprobravin. So there are so many genes which can cause or initiate the schizophrenia. Okay, genetic factors are important, followed by the biochemical factors. So the main neurotransmitters implicated in the development of schizophrenia are: one is dopamine. Dopamine is the main thing, which is the main neurotransmitter in depression. अभी सर ने बता दिया ना, serotonin. Serotonin is the main neurotransmitter involved in depression. In schizophrenia, it is mainly dopamine. Okay, so the positive symptoms of schizophrenia can be attributed to dopaminergic hyperactivity. Okay, dopaminergic hyperactivity. High levels of dopamine can cause positive symptoms of schizophrenia such as delusions and hallucinations. And low levels of dopamine can cause negative symptoms of schizophrenia. So dopamine is the main neurotransmitter, followed by serotonin. Hyperactivity of serotonin can cause schizophrenic symptoms, and also disturbances in the levels of norepinephrine, GABA, and also glutamate. So all these neurotransmitters are implicated in the genesis of schizophrenia. Okay. Then coming to the neuropathology behind schizophrenia. So the main pathological changes in the brain, one is in the cerebral ventricles. Okay, cerebral ventricles. So these changes we can see after death. Means these are all are the post-mortem studies. Okay, post-mortem findings. So on post-mortem, there will be enlargement of the cerebral ventricles. Enlargement of the cerebral ventricles, mainly lateral and third ventricular enlargement. Lateral and third ventricular enlargement, and there will be atrophy of the cortical grey matter. Atrophy of the cortical grey matter, and reduced symmetry in the lobes. Symmetry in the parietal, temporal, occipital lobe. Symmetry will be reduced, and the other main system affected is limbic system, which is concerned with the emotion. Okay, so what are the changes in the limbic system? There will be atrophy of the structures in the limbic system, such as amygdala, hippocampus, and parahippocampal gyrus. These are the main structures of limbic system, and there will be atrophy of all these structures in schizophrenia. And also there will be structural and functional disturbances in prefrontal cortex. Prefrontal cortex, and also there will be atrophy of the thalamus. Thalamus atrophy and neuronal loss in the thalamic area, and also basal ganglia and the cerebellum. So, what is the connection between schizophrenia and the basal ganglia? Is there any connection? Have you seen any schizophrenia real patient? Okay. So is there any movement disorders related to schizophrenia? Because basal ganglia is related with the movements. Cerebellum is also for balance. So what is the relation? Catatonia. Catatonic symptoms will be there. And you can see stereotypies. Stereotypy matlab repetitive action, same action. So stereotypy, and some patients you can see grimaces, facial pitching, grimaces. So all these abnormal involuntary movements are related to basal ganglia. Okay. And next coming to the psychosocial and psychoanalytic theories related to schizophrenia. And the main theory was proposed by Sigmund Freud. You know Sigmund Freud ka contribution. Who is Sigmund Freud? Who is Sigmund Freud?